Well, good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor and CEO of VBC Exhibit Hall. So I'd like to welcome you all to today's live webinar hosted by Avery Telehealth. And today's session is called Member/Patient Engagement that Moves the Needle, Strategies that Scale. And they're going to be covering a lot of practical information today. There's going to be a lot of great takeaways. So I think you'll really enjoy the presentation. But a few items of note before we get started, and then I will introduce our speakers. Everyone has joined today in listen-only mode, so this is a traditional webinar format, so we can't see you or hear you. However, we're going to have time for some Q&A towards the end of the session. So if you have a question for either of our speakers today, feel free to drop that question into your attendee module. There's a place specifically for questions, and we're going to get to as many as we can. If we don't get to yours, though, for some reason, don't worry. Someone will reach out afterwards to make sure that we answer your questions. Also, the session today is being recorded. So what's going to happen is when we conclude, maybe about an hour or so after we wrap up, you'll receive an email, and there will be a link to the recording as well as to the slides from today's session. And that way you can watch it again as needed and share it with colleagues and friends, and we hope that you do. So without further ado, wanted to briefly introduce our speakers today. With us we have Mr. Mark Aspenson. He is the Chief Executive Officer with Avery Telehealth, and also Renee Garish, and she is the Chief Success Officer. So welcome to you both. Glad to have you.
Thanks so much,
Thank you,
Garrett.
Garrett. We're happy to
Appreciate,
be here.
yep. Thanks for all of your time in putting this together. For us, we're excited to have, looking at the attendee list, we did use kind of the topic of both members and patients. We got a lot of ACOs that are on the webinar, as well as health plans, or really kind of anyone that's at risk for patients, or what we're going to call probably participants today. So Renee both have a lot of experience when it comes to overall engagements and outreach, and a lot of virtual care. So a lot of our experience comes from remote care versus we do have hands-on care, but we don't do a whole lot of hands-on care at Avery Telehealth. And happy to answer any questions that you have kind of along the way. We'll try to make this more of a conversation between us versus a lecture. No one likes being lectured at, but we'll kind of get right into it. And I think when we talk about patients or members, and we talk about engagements from a healthcare executive standpoint, we oftentimes look at numbers, we look at rates, we look at total cost of care. But I think sometimes we lose sight of the importance of how important it is to engage with the members or the patients that we're interacting with, and how that really can make their life better. So I'll have Renee kind of give you guys an example of a real recent engagement that we had that had a phenomenal outcome. So go ahead, Renee.
Thank you so much, Mark, and welcome everybody. I'm pretty excited about sharing this story only because it really stays with me all the time. We recently had a member that was being engaged by one of our RNs. And with this member here, he was just recently implanted with an LVAD. He was disconnected, didn't want to, persist with his conversations. He really showed a lot of signs of, suicidal ideation. He stopped taking his medications. He stopped with his care. He didn't want to talk with anybody. And just persisted in that way. Our RN did escalate it to one of our NPs, and the NP reached out. He really didn't want to talk. He didn't want any more calls, but she actually made a personal connection with him. Ironically enough, the place that he had his surgery is the same place she had worked at a previous time. So right then and there, it made a bond and a connection between them. They worked through their scenario during that call, and he had committed to a call the next day as a follow-up to see how he was doing. He didn't show up. She tried 3 more times to engage with him over that next hour. Still no return, still no pickup. So it was a determination to actually reach out and do a wellness check and have, emergency services go out and check on him. The next day, we actually received a call back. He called back to the RN who was part of his caseload. And this time, he actually asked for the video visit, not necessarily being provoked by her. He shared the difference that this made. If you had a person, reach out to me Then you had a nurse practitioner call me, and then you had emergency services come out and see me. That tells me that you care and you heard me. So he recommitted to taking his medication. He recommitted to doing his follow up visits. And he also reached out to get home health care to come in and help him through this very trivial time that was going on in his life. It was pretty exciting to hear that turnaround time, because the next thing he shared with the RN is that you guys made me feel human again. He had a revitalization in life, and he was committed to seeing past this change in his life and moving forward with it and making it the best possible. So when we think about this isn't just a clinical win, but it was also a human win. It was an outcome that we all strive to get. And so I thought it was really a great opportunity to share that with you today to kick us off for the rest of our conversation.
Great. So that's obviously a great kind of example of the power of of meaningful engagement with members, and now we can also get into the nitty-gritty details of some statistics about engagement as well. So when we look at some of the engagement gaps throughout the country, you have some digital access barriers. You got 42 million with a lack of broadband access. We were just on a call last week with a group out of New Mexico that a lot of their members don't even have access to electricity. So it's not just broadband stuff, but it's also even electricities or phones, or how are you going to physically engage or digitally engage with the members? And obviously that's disproportionate across the rural or lower income spectrums, which a lot of you are taking care of on the Medicaid side of the equation. Health literacy, only 12% of the adults, the U.S. adult population have health literacy. You certainly need to make sure, that you're using the Flash Kincaid, making sure that literacy that you're putting out there, whether it's literature, whether it's text message, whether it's portals, whatever the case may be, even on your patient discharge instructions, to making sure that, if it's at a fifth degree or a fifth grade reading level, that's kind of to make sure that you're getting the most amount of literacy out there. Heard a lot about patient portals that are not really being used. I know it's one of the four pillars for a lot of care transition planning, but the utilization of health workers just isn't very high. So how do you make sure that they are overall engaged in their health from time to time? Then you're also looking at the missed opportunities for engagement. So 77% are skipping preventable care. So I know a lot of you are, in the Medicare Advantage space, where we're getting a lot of calls right now to help out with annual wellness visits because they haven't done them so far this year, and you want to get them done for your Medicare measurement period before the end of the year. So that's certainly things that we're very familiar with, and sharing some of your concern as well. And then obviously by not getting that preventative care, not engaging, that surely just drives up costs. It's estimated it's $150 billion a year problem of not engaging with members. So we also look at, the limited English patients is really driving between 20 to 40% lower engagement rates. So when we're talking about the language barriers, are they understanding what you're trying to get them to do? Do you have people that are we'll talk about speaking their language, in a little bit as well, but also from a national perspective, when you guys go out to budget or look for your targets, we're going to do a little bit of an audience poll here. Garrett will help us out with is, from a standard engagement target, what percentage of your populations do you like to get engagement with? So, Garrett, do you want to take over and do the little audience poll?
All right, sorry guys, working live here. Pulling up this poll right now for you. You're going to see this launch on your screen. For outreach programs, what is your target engagement rate? Is it less than 26%? 26 to 30? 31 to 35? 36 to 40? Or above 40? And this is just to choose one, of course, that best applies. And this is anonymous, by the way, these polls. We're going to have another one a little bit later on. And so this is, and we're going to show the results so you can see it, and that way you can kind of see where you stack among your colleagues. I think most of the results have come in here. Gonna give it a few more seconds and then we'll close it down. All right, I'm gonna go ahead and it looks like most things have come in. I'm gonna go ahead and close it down in another 5 long seconds here. 5, 4, 3, 2, and 1. That's a long 5 seconds. Here we go. All right, Mark, Renee, are you able to see these results on your screen?
Yeah.
Yes.
So do I need to resume sharing here? Or do you
Oh,
see my screen?
let's see here. I'll tell you what. I'll read them out to you if you're not able to see them. So we got 13%. That's no, you don't need to resume sharing, by the way.
Okay.
Less than, oh, I'm sorry, 13% said less than 26%. We had another 13% that said 26 to 30%. 20% of you said 31 to 35%. And then 10% of you said 36 to 40%. And then the vast majority here above 40%. And so the 43% of you said above 40%.
Great. Let's look. That's a great target. We got a good audience. The majority of our customers are at 30%. So you guys are certainly ahead of the ball game, which is great. So here's kind of, the one thing when we talk about some of these national benchmarks that we're hearing, engaging with the eligible vendor is kind of in line with where you guys are at 35 to 45%. The completed engagements of not just one unique engagement with a member or a participant, it's really how frequently during that engagement period, whether it's 30 days, 90 days, 6 months, how many engagements are you actually getting is usually 1 to 2. Um, the big issue, and this is Renee's hot button, is the data integrity or bad contact information. It ranges anywhere from 25 to 35%. So we'll talk about that. Anything we can do to help make sure that the members that we're actually reaching out to, we don't have bad phone numbers for that kind of stuff. That makes a huge difference when it comes to engagement. And then more importantly is the active decline rate that between that 10 to 15% is what we're seeing as well. So without further ado, this is where Renee does all of our data uploads and gets large census files to try to import into our platform. And this could literally be a picture of you, Renee, pulling your hair out about some of the data feeds that we get. So you had talked a little bit about kind of what you're seeing when we get these data files for large member populations, and what has to be done to kind of filter through them to ingest them in, and what could be done to make it more viable.
Yeah, absolutely. And thank you, Mark. So when we talk about, bad data, it is a broken engagement. So when we think about it, bad data isn't just inconvenient, it's the fastest way to lose that and get a broken engagement. The great news is that it's fixable. So when we look at the opportunities that we have is really just at every avenue and every opportunity is verifying that best phone number, whether it's a home or, a cell phone or any of that information. That also goes with verifying email because that's another engagement opportunity avenue that you can use. The key to it is really updating all the data locations within your EMR or your billing software, or anything that you do where you extract that data to send over to anybody to do your engagements, whether it's your engagement team through call campaigns or any of those methods of doing your engagement. That's including the emergency contacts. So think about it as this way. Every disconnected phone number, outdated email, unverified contact chips away at that continuity of care, that engagement opportunity. So when we treat data integrity on the frontline strategy, it actually works on the back end. So don't look at it, as a chore, but really just trying to really get it to achieve it. Um, I look at it as this, is that when we have bad data, we turn that and we get good data, we turn that can't reach into a just reached. So it really comes down to starting at the front line, passing it through all your portals and getting it to the right place. So that way, when you're extracting that for your engagement opportunity, it's a win. It's a win for the outcome. It's a win for engagement. It's a win for that continuity of care.
Yep. We have a lot of ACOs on the call today, so just making sure that providers, when they are in the office, right, is verifying that information at each visit. And then even if you do have the ability to identify what method of engagement that you want, whether you want a phone call, whether you want a text message, whether you want an email, knowing what that preference is on the front end certainly helps with engagement and outreach programs as you progress as well. So here's kind of what we have as far as engagement tactics is kind of another audience poll. So Garrett, if you want to look at what do we have kind of for our next uh,
Right.
method of engagement.
Yes, sir. So you should all see this pulled up on your screen now. And this next question is, which outreach channels do you currently use to engage members and patients? And this is choose all that apply here. So this is, was it phone calls, SMS, text messaging, email, mailers, or printed material? Or is it multi-channel mix based on preference or timing? And again, this is a choose kind of all that apply here. And we'll give it a few more, maybe 10 or 15 more seconds for people to put in their answers here. And then show you the results. And again, if you're just joining us now, this is an anonymous survey, so this is just kind of more for fun and show you kind of where you stack among your colleagues, and we'll show the results here momentarily. Okay, so I think most of the results have come in at this point, and we're going to go ahead and close it down in 5, 4, 3, 2, and 1. All right. So I'll go ahead and read out the results here. So 71% of you said phone calls, 42% SMS text messaging, 46% said emails, 42% used mailers or printed materials, and then 58% said a multi-channel mix based on preferences or timing.
Terrific. That is great to know, and it's good that we're seeing a lot of more multi-channel. The phone calls are great. They're more expensive, so you want to make sure that you're able to get a little bit higher hit rate on some of the phone calls. So we'll talk a little bit about that. But it's great that everybody's doing a lot of different things. So here's kind of, when you're looking at engagement, we talked earlier about what's your target engagement levels. A lot of you want to be above 40%, which is great. But when we look at our overall engagement, it really needs to be also who's eligible for engagement and how frequently are you really able to connect with people that you have the right information for. So here's just this is just round numbers that we've used from, some of the stuff that we've done in the past. So say you have 10,000 members on your census, bad data, or there's just no way to connect. Either the phone number's bad, it's disconnected, the list that you provided didn't have a phone number in it, or no way to contact them. It's 25% of the people. You're going to have some people that are ineligible. Maybe they went to a sniff. Some people, turns out, maybe they're in hospice. Some people have left the country. Some people may have been deceased. Like there's a large number that not a large number, but there's always people that are just ineligible. So if you factor those things out, now you're down to 7,350 people. So now you're down to 74%. So already 25% of who you're attempting to get a hold of are not eligible for engagement. And you're going to do your outreach, right? So you're going to try to get a hold of them and say that 27% of those people you're not able to get a hold of the people that are eligible. But the thing that really, is going to measure your engagement success is who have you offered some type of program to, whether it's an annual wellness visit, whether it's a specialty program for heart failure, diabetes, or whatever the case may be. So have you actually offered a program you explained the program to them and they said, hey, I'm not interested for whatever the reason is. Maybe your daughter's a nurse or they get home health involved or they just flat out don't see the value in the program. And that's at 10%. So really anything that you can do, our goal is really to make sure the active declines are really under 10%. is what our goal is. So when it's all said and done, you started with 10,000 members. You've really engaged 4,600 of them, which is, for the total engagements at 46%. But of those that are eligible, you're at 63%. So that's not terrible, right? So anything you can do to really increase, obviously, the the number of eligible members, so reducing the bad data, which Renee talked about, and then obviously making sure that you're reducing any active declines. That's a big part of kind of redefining, kind of how we, advise people look at overall member engagements. Renee, did you want to add anything to that?
Yeah, I'd really like to tag on to that active decline. So, thinking about a lot of the use cases that we've had and we've learned over time and time again is that the active decline is an intentional, disconnect. And just listening and hearing from some of these folks, it's all about awareness and knowledge too. So it's like, who's reaching out to me? Are you legitimate? Are you a scam? And just really sharing with your patients or your members that people are reaching out to them by phone, by SMS, by other means to get these needs and care initiatives and everything out to them. So I thought that that was a valuable thing to add to those active decline numbers.
Yeah, definitely. I mean, there's scams going all over the place, right? So, and specifically about health, right? And specifically, a lot of our, members are seniors. So anything you do to make sure that they know that it is legitimate when someone does call and they reach out, it's okay to talk to them. If they're identifying themselves within the health plan or the provider, so on and so forth. So I think the other thing is really knowing the rules of engagement. If you look at a lot of outreach programs, we do a lot of transitions of care programs, and compared to, someone's being discharged and the protocols are calling 2 times over the course of 30 days, we don't feel that really moves the needle a whole lot. So, we're looking, typically what we're looking for is the ability to do up to 6 attempts to someone. We've had some customers ask us to do 12. We think that's a bit excessive. But then other people's, just ask for 3. We don't think that's quite enough because, sometimes, as Renee was mentioning, you're going to get a busy signal or it's been disconnected, but then the next week they may pay their bill and be able to get hold of them, whatever the case may be. So if you look at, if you want to talk a little bit about this, Renee, as far as you just can't give up, right? So if it's, just as kind of the poll had said, there's still about 70% doing phone calls, which is the most effective. But then you kind of have a diminishing return on the text messages. So do you kind of want to walk through a little bit of these numbers? And I think you had mentioned, we were talking earlier about, completing some of these SDOHs for members, 10% of them we get on the 6th call or something like that.
Yeah, that's absolutely correct. So, for each program, for each type, you all everybody sets a standard of number of calls or attempts for engagement. And as we're seeing here, now in this day and age, everybody is SMS. So we really try to push that drive at first and second attempt at that engagement. That's when we're going to get our biggest engagement rate or return. And then from there, we can find out the method that works best for them, whether it's, telephonic, video visit, by any means. So we have tried many variations of, up to 3 call attempts, up to 4. We have a use case specifically that we were doing many different engagements, specifically an SDOH engagement process, and we found a 10% increase of engagement completion at that 6 call attempt. So that was a surprising find in this patient population that we were doing, or member population that we were doing. So we increased doing that across all their, SDOH, med review, and even that high risk case management nurse review each time. And we saw that across the board there. So it is really knowing that population on what best meets with them and that best method.
Yeah, and then also if you want to talk a little bit about, the average number of engagements. I mean, getting a hold of someone once, does that count as an engagement? Yeah, it does, right? But if you're not building a relationship, if you're not, having them willing to engage with you in the future, how successful really was that engagement? So you want to talk about kind of that, what do you have here, 3.17 touches?
Yeah, that's where we really get into that continuity of care with that, building trust and building that commitment with the person that you're engaging with. Um, Knowing that person you're speaking to. So on most occasions, if you connect with them and bond with them day one, they'll actually stay on and do the number of engagements, assessments, or whatever that you're asking them to do. And we found over time, most of them will do up to 3 assessments on that first call. If not, they schedule it out for the next time. And they'll commit to it. The same thing with doing telephonic versus video visit. Some of them will engage on a video visit first attempt, and then some of them will say, can we do telephonic first and try video the next time? It's just that apprehension of overcoming that technology change for
Hmm.
them. And we have found it very successful, just really listening and understanding and hearing what they're sharing with us for best success.
Great. Well, there's always this, member fatigue, right, or patient engagement, right? So, from finding a balance of, we do a lot with the, transitions of cares, everyone's calling them, right? So you got the hospital calling them, you got the doctor's office calling them, you got home health showing up, you got a disease management company, you got the health plan calling them. So they're just really overwhelmed, specifically when they're just being discharged from the hospital per se. But what's the best way, or how have we really kind of found, and then you can't just wait 6 months to call someone, like, a lot of the traditional disease management programs where you just wait too long either. So, how are you able to kind of say, hey, when's the right time to engage with a member? And, they may be feeling great one day and terrible the next day, or, what's the best way to find that right balance? So I think that the one thing that we also, offer is making sure that if we looked at the multi-pronged approach, one way to do it is if you use technology like the texting program. So you can have a wellness check-in, right? A texting program that sends them a text either once a week or depending on their acuity level, a couple of times a week, is saying, how are you feeling today? And they have the option to respond, good, and then saying, we're glad you're doing great, nothing happens. Or if they're starting poor, say, hey, we'll have, someone to reach out to you that same day. And that's where you're able to really drive more timely engagements with the member. Obviously, they're not feeling there, where they're more susceptible to, or more likely, I should say, to pick up the phone and talk with you, right? And then you're not calling them on days that they're doing great, right? So that's one methodology that you could use to put in place, is how, when you have that multi-channel approach of texting, emailing, or phone calls, to make sure you're not wasting phone call time. Anything to add to that, Renee?
I think you said it very well.
So this is part of, when you're doing outreach, and this is specifically, probably more related to phone calls than it is text messages. But really analyze, don't just set it and never analyze it if you're not getting the return that you're looking for. So this was kind of one of the analysis that you did on one of the programs. And you want to talk about, Renee, like what changed?
Yeah, as you can see, the peaks and valleys here, and this is week over week. So, oftentimes many programs listen to the messaging of the folks that are doing their engagement opportunities. And for us here, we have been very aggressive in watching that, especially when we start a new program. The peaks and valleys here show that we've made an adjustment in our messaging. So, are we leaving a message that's purposeful, that is intentional? Is it going to resonate with that person that we're reaching out to, so it prompts them enough to give us a return call? So every time that we would tweak that messaging, you'd see a peak here on those weeks. That just goes to show that that standard norm, those bots, those automated messages that you use time and time again, is how often are you listening to them? How often are you adjusting them to meet with that population you're trying to engage with?
Right, and if you're not like listening to the people doing the outreach calls, you can't really change the message then either, correct?
Exactly. So that's very important to just really tap into. If you do a text, a speech to text auto message, you do lay down messages, you do any of those types of things, it's not only listening to the calls of the humans, but also the technology. If you're
Hmm.
adjusting in one, adjust in the other. So that way you're demonstrating even through technology, a human's at the other end of it. Still, these, patient or member populations still want to know that there's a human behind that technology. So these kind of,
Hmm.
adjustments and everything kind of demonstrate that.
Okay, great. So we talked a little bit about language barriers at the beginning, where English may not have been the first language. So this was kind of an interesting stat that you had found with one of our customers, where it comes to, speaking their language, and specifically kind of what's highlighted here is kind of the Russian population. So you want to speak a little bit about that?
Yeah, absolutely. So within this member population, there was 18 different languages that was actually spoken. And ironically enough, our Hispanic population was the most engaged. They were so excited to hear, a Spanish-speaking individuals, calling them and engaging with them. But the Russian one was even more intriguing because when the clinical team reached out to them and they could speak Russian, they would start in Russian, but then they would convert to English. And they would say time and time again that, it's like the respect and the trust and everything it did to show that they would speak in Russian, but then go convert to English was a really
Hmm.
telltale for us to say, sometimes we have to make that extra effort to engage and build that bond.
Yeah, and obviously, the trust as well is that the understanding, the health literacy of speaking their languages can only help, when it comes to that. So that was a
Yeah.
very kind of interesting statistic that was kind of surprising.
Well, as we've learned through all these different languages, we actually, engage, set up our platform to engage with people in 30 different languages as a result of it.
Yeah. Um, so this is, kind of part of it was is understanding like what language do they prefer, right? But also, making sure if you want to build, engagement and get participants to engage, from day one, you really have to know these people. Like you kind of what you had mentioned earlier, you can't just have random phone calls, dialing for dollars type of, scenario. Is that you really want to know as much information as you can about the members of, if it's a, transition of care program, why were they in the hospital, not just that they were there. If you're getting a daily census of they're there, they're gone, they're at this place, and you don't know why, it's very tough to engage with them if the person doing the outreach is just kind of flying blind, right? So understanding why they were there, getting those data feeds, and EHR feeds. So their history and physical kind of, and then also doing their overall assessment of what they really need, whether it's a high-risk case management note, whether it's a med review, whether it's an SDOH, is really getting to know what's important to that individual member and what's going to fuel them. And they don't, maybe they have a mental health issue that they don't care about their pneumonia that they were just there for. So really engaging with that member and giving them the resources that they may need. Maybe they don't have food, or maybe they're getting evicted and their health isn't important, but making sure that their kids have enough to eat, right? So those are all different things that with the wide variety of populations that we deal with, that you really need to have people that have a layered multiple, but they actually have to exercise their overall judgment, right? This is why we don't use robots to do this. Like AI is great and it's certainly kind of helping things move things in the future, but there's no way that AI is really going to help determine for someone, at least as of now, right? Of kind of the things that we just mentioned, is that you really need someone to exercise their clinical judgment to make sure that the next time they call that they're or outreach that they're going to participate in whatever the program uh, may be. Do you want to add anything to that, Renee?
Yeah, if I could. So when we even look at, bullet three there, encourage the repeat engagements. One of the things that we learned from program two is, if you're going to do an SDOH assessment or any other type of assessment, and you learn something about that, patient or member, is that you do something about it. You follow through with it. You follow through with it in any different means, and even, follow back with them. So many times you hear from programs that or from members and participants that someone called me, they did this assessment, but I never heard anything. So really
Hmm.
just having a plan in place that if you learn something that is really crucial, like you said, no food on the table, no, rent, no rent money to pay for housing or anything. What are we doing about it to help them? Are we really helping them? Are we putting a plan in place not only for healthcare, but for all these other means that they have needs for that really builds that full picture for them?
Yeah, and also, to set the stage for their member engagement experience, right? Is when is their next phone call going to come, and who's it going to come from, and are you going to be put in a queue, or are you going to be assigned to kind of the same clinical team, so on and so forth, is really going to help make sure that these repeated engagements um, are met. So, also it's when we talk about engagement, it's also looking at all these barriers. And if you're not getting engagements, why is that, right? So when you look at kind of, this is that kind of same use case that you're using, but, talk about kind of why most people, why we go so in depth as to why people aren't engaging. Go ahead, Renee.
Oh, I'm sorry. So here, when we talk about, those engagement dispositions, it's like, what are we doing with them? Are we just looking at the stats and saying, okay, well, that's respectable, that's reasonable and everything. But when you actually dig down to them, they're actionable items. So, and anybody that you speak to, it's like, what can we do about disconnected numbers? Well, at times it's nothing. But there is something we can do about people not setting up their voicemail. There is something that we can do about, education about people are going to do outreach. So it's really looking at those engagement dispositions and taking those actionable ones and having a plan for them. So it won't be 100%, but chipping away at it and getting even 10% or 1% time again, you're getting closer to that really magic number that you're looking to do, and you're really reaching those members for engagement.
So when it comes to avoiding overload and respecting member engagement preferences, I think the big part is understanding once you do get a hold of them, one way or the other, what's their willingness to engage, what's their preferred method of engagement. So maybe you have that up the front. Maybe it's like when we outreach to them, it's figuring out, what it is and what frequency it is. Um, I remember we had one member that was a Medicaid member in Southern California, and they just had limited cell phone minutes, right? And this was a care transition program, so we're trying to get a hold of them for the next 30 days. But they didn't want to participate in the program. They were turning us down. And we said, our nurse did a great job of improvising and saying, hey, look, what are you willing to engage with? So if you have limited cell phone minutes, how about I outreach to you once a week, right, for the next 4 weeks? However, if you experience any of these symptoms, and I think they were probably a heart failure patient, right? So, any shortness of breath, any swelling in your feet or ankles, all those types of different kind of triage symptoms that they really need to kind of work on, change any side effects to medication, so on and so forth, to give us a call. And that member actually, they enrolled the entire 30 days. They took the phone calls to 4 times. They didn't get readmitted. So we just can't have a one size fits all. Like, you have to abide by these protocols or you're out of the program, so on and so forth. So I guess probably unless it's some clinical trial of some kind. But we just want to make sure that it's more. We feel like it's more important that the patients or the members stay engaged for whatever they're willing to do versus following some strict protocol that we have in place. So, do you want to talk a little bit about understanding the purpose of the call? A lot of times they're like, well, why are you why are you even calling me? And why should I participate? Why should I engage in the program?
Yeah, it's often questions that are posed back to any of our you know members that are or people that are reaching out for these engagements. So it's really all about awareness, right? That continuity of care, and just helping them to understand that we're there to provide education. We're there to help them in between their visits. So they have another number that they can reach out to where, especially where if you have a clinical team that is doing these engagements. And oftentimes we get a call, and we had a unique one that just called in and said, I'm going to be away unexpectedly for 2 weeks. I'm going to visit my son. I just wanted you to know. That's how
Yeah.
much of a bond that you can build through understanding, where they are, and that awareness, that education, that clinical education, or the purpose and the intent of the engagements that you're doing. So the more that we let them know, not only for anybody reaching out, but coming from providers, coming from, health plans and everybody, is just making their members and their patients aware that this engagement process outside of the office is going to happen, and it's for your continuity of care. So you have other people to reach out to make sure that you're keeping well, that you're going on to meeting your goals that have been established in your care plan.
We talked a little bit about the robo dialing or the robo messaging, that where it's just repetitive. There's nothing personalized about it. Like it's just kind of like a spam message. Like why would they want to participate in that?
You're exactly right. So we get a lot of feedback a lot of times when we'll call back a second time and they'll recognize the number, and it's like, okay, someone call me back again. And we hear so often it's like that repetitive messaging. A lot of people nowadays are so groomed not to pick up calls. It's going to be a scam.
Mhm.
It's going to be something. I don't recognize the number. So, most of us
I
that
don't pick
do
up. I don't have I don't have a chance of picking up the phone if I don't recognize the number, Renee.
exactly.
You leave
And
me a
there,
voicemail, then I'll listen to the voicemail. And if the voicemail speaks to me, maybe I'll call you back. But otherwise, there's not a chance.
And that's where the messaging with intent and purpose comes into play, Mark, is for people just like you. So if we don't put that in place, and we have that multi-prong approach, try to get these people attention, members or patients or otherwise, it's like they're not going to engage. They're not going to reach back. They're not going to engage in their own care. So it's people like you that we're trying to overcome every day.
Yeah. So the other thing with a lot of these health plans, there's some of them have millions of members, some of them have 100,000 members. You know, how do we make sure that they know that they're not just a number, right? That they actually matter, right? And I think that the big strategy that we put in place related to that, and we encourage people to do, is don't put them in the queue, right? Sign them to a team, build a relationship with that member, kind of exactly what you're talking about. Of hey, they should be invested. Like if they're gone for 2 weeks, and they take the time to let us know. Like that's really a win, right? That we've engaged with those members. So we strongly encourage you guys to make sure that they're assigned to the same team. Like putting people in queues just it really doesn't work for any long-term engagement. If it's just a one and done type of thing, we understand. But any long-term engagement, make sure they have a dedicated person or team. And there'll be multiple people on the team a lot of times. So there'll be a couple nurses, a nurse practitioner, a social worker, but it should hopefully be the same team that they're reaching out to.
And it does have an impact in that respect, most definitely. Hmm.
Yes. So when we talk about structured outreach with intentionality to drive results, this is kind of what we talked about with the poll of having a multi-channel approach, right? So, this is just an example of a heart failure program that we do for programs. It's just a 30-day program, but essentially you have your live calls in like the dark blue, the text messages in the light blue. Um, you know, and then look at the topic. Like, does it make sense to have a call related to this? Can you just send a text message related to it? So, if you need to send someone a reminder to take their weight and take their medications, that certainly could be a text message. It doesn't need to be a live phone call for that, but it one talks about putting action plans together for their help. Like that really probably needs to be a live phone call. Or, if it's medication management, a medication review, you really can't do that via text message or email. You really want to make sure. Obviously, the live calls or videos. You do video visits too. Those are kind of the same. But that's kind of what we kind of advise people to do is use a multi-turned approach, a multi-channel approach. But make sure when you're creating the topic for that individual day or that individual visit, then it makes sense to do it based on that modality. And then again, like we don't, a lot of the, the programs that we've dealt with, whether it's high risk case management, whether it's disease management, you really can't encourage engagement if you're waiting 90 days, 120 days, 6 months to engage with an individual member. That just, it really doesn't work. I think if you were to do that, you certainly would want to put in like a texting wellness check-in program so that you can get a hold of them when they really do need the care, that there is outreach occurring, that it's not just waiting 6 months for a phone call. Anything you wanted to add to that, Renee?
No, I think that you spelled it out very, very well.
Okay. So this, Garrett, we kind of saved some time here for some Q&A if you want to get to that.
Great. And we do have a bunch of audience questions, so we're probably not going to get to all of them. But if you have a question that you'd like to ask, please drop it in now using your control module. If we don't get to yours, though, don't worry. Someone will reach out to make sure we answer it via email later. But in no particular order, let's go ahead and hop in and ask this question first. Do you have any suggestions for voicemail messages that generate the most callbacks from members?
Go ahead, Renee, you're the expert with that.
Yeah, so it really comes down to the type of program that you're setting up for those engagements. So we have to remember that there's a lot of pay-as-you-go phones now, so you have to be
Mhm.
mindful of those minutes and availability that they have. You get that 160 characters, so it's really, again, being purposeful and with intention on that message that you're setting up and teeing up to catch their attention and for them to respond back.
Well, I would make sure that you have a live voice, right? So even if your program has a recording, right? Make sure that it's a live voice recording and not a computer generated voicemail. Those are kind of the big things. And then I would make sure if you have the ability to put their name in the voicemail to get a return call, and that the put a name to who is calling. So when they call back, ask for Renee, ask for Garrett, right? That it's not just general. They have a point person to talk to versus just kind of a general queue if you have that capability.
Great suggestions. All right, next question here is what level of staff do you use for your customers' patient outreach? Like, is it RNs, LPNs, MAs, CHWs, or just a really smart person?
That's a great. Well, we hope all of them are really smart. Sometimes we're better than others, but it's all levels. So it really depends on the program. But we certainly have nurse practitioners, registered nurses, we have social workers, we have medical assistants. So it really depends on the program. We try to schedule a lot of the visits ahead of time. So if they're scheduled with an NP, obviously we don't need anyone else involved. It can be a live phone call, it can be a video visit with the NP. But a lot of it, I'd probably say like 2/3 of them are RN visits. So we do a lot of nursing visits.
Yeah.
All right, moving right along. Next question is how do you recommend adjusting engagement strategies when a member seems stuck or unresponsive to interventions discussed in outreach calls?
That's good. I'd start by even asking the question, what are their goals for their individual health, and what do they want to get accomplished? And then in addition to that, what additional resources do they feel like they would need to kind of get there? Um, so those are probably some strategy we would put in place. Um, maybe they need a social worker to call. Maybe they need a specialist. Maybe they're trying to get into a place and no one's letting them in. Maybe it's a network issue. Maybe, if we call the doctor to get them in, maybe they can get in themselves. Maybe they're struggling to get appointments. There's a lot of different things that we see that are just barriers to care. And whatever we can do to help remove those barriers, the more willing they are to participate. And then even sometimes it's the education is providing them with education and letting them make their decisions. I mean, one testimony that I've always liked about a diabetes program we had was they were enrolled for 6 months, and then at the end they said, now I drive past McDonald's versus through McDonald's. And that was a great testimony. It wasn't the fact that we're trying to say you can't do this, but you give them enough education, and hopefully they're going to make their own decisions. And then, we saw their blood glucose spike, when they were going there, right? And they weren't losing any weight. And you start to build that rapport with them on an ongoing basis. Then they'll start to build trust with you, and then they'll start to listen to you. I mean, sometimes they'll tell us stuff that they won't tell their doctor, they won't tell their family. It's all about kind of building that rapport to move the needle. Anything else, Renee, related to that?
Yeah, a good example too is time and time again, whether it was RN, social worker, or otherwise, they would actually do a three-way call to that specialist or their their PCP or provider to help them schedule that appointment because, at that time when they called in, their Spanish-speaking staff member wasn't there, their Russian-speaking person wasn't there. So, our clinician could translate for them and get that scheduled and make it happen. So there's other avenues. It's like just helping them, hearing them, and supporting them the best way possible.
Great. Next question. What equipment are you using for call, text, video? Are your staff all using cell phones and FaceTime?
So we use our platform. So within our platform, we do calls, we do text messages, we do video visits, all within our individual platform. So we just have to give our staff usernames and passwords. Same thing, we're able to send just a text message for a link that's all HIPAA compliant, secure to the individual member. They just click the link, and they are able to pull up the video visit. So it's all kind of self-contained within our platform. What else, Renee, related to that?
I think you said it well. That captured all of it.
You got to make sure. I will say, Garrett, if you want to do a video visit, you got to make it very simple for them to participate. So you clearly have to make
Mhm.
it secure, but making them log into a whole bunch of different ways and remembering their passwords, all that kind of stuff. From downloading apps. We have an app to download, but we don't require an app to download to do a video visit. So you got to make it easy for them to participate.
Great. Next question here is what strategies are most effective in engaging parents regarding their child's health needs, especially when families are overwhelmed or unsure about next steps?
Renee, you want to
We
take
all,
that one?
I was going to say we almost have it in the reverse with some of the use cases we've had where, you know, um, children have become adults, but they still have their parents' information as their contact
Hmm.
information. So it's really trying to get through those parents to get to those now adult, members or patients, so that way we can engage them directly. Um, it's just really about the same thing: communication, understanding, educating, with them, so that way you're helping to, solidify that commitment between the both of you to support it.
I think the other thing, we don't do a ton of pediatrics, to be honest, but I will tell you that you really got to make sure that you're available when they're available. So in the event that they are working, 9 to 5, whatever the case may be, is you got to have a team available either before work, during lunch, during a break, after work, to help them. Otherwise, if your availability is only during the workday and they're already at work, it's going to be an uphill battle.
Hmm.
Well, and you have a good point there, Mark. That's where we build in a little of that nimbleness, right? So not only do we stay within the confines of the time appropriateness by time zone and everything, but we also create that availability, even on some Saturday hours and stuff for programs. So that way, for those that have that work day within those constraints, there's also an outlet or an avenue for them to reach out and get that care as well.
All right, we've got time for a couple more here. What's one change an organization could make tomorrow that would have an immediate impact on the engagement rates?
Where do you want to start, Renee? That's a lot.
I the biggest thing that I hear time and time again from so many members or patients is that they were not aware that they were going to be outreach to. So, that would be a number one thing that I would put on the table, is just really making your patients or your members aware that part of the engagement team, whether it's clinical or non-clinical, you're going to get a phone call or a text or something for an initiative that's going on. That would be my top one.
Yeah, it's a big engagement for, hundreds of thousands and millions of members. It's a big topic at hand. I would start with your highest risk members, identify who they are, and come up with a plan and stick to the plan. And
Yeah.
you can't be all things to all people, but certainly the ones, if you're taking your top 5% of costs and you really want to try to drive down costs, start there and then see whatever you can do on it. But then you also have to customize it to what that individual member needs. But you got to identify who you really need to get after.
Yep. Next question is, and you may have just touched on this, and you shared some great examples of engagement tactics. Which one has surprised you the most in terms of effectiveness?
I think the wellness check-in is probably, I mean, it's not a silver bullet by any means, but if you've got a large population you're trying to manage, you're trying to do outreach to them, you really don't know when they need outreach. I mean, you have an idea unless you get an ADT feed that they were just in the hospital. But if you don't have any other encounter data, you never know when they're doing, how well they're doing. So if you're able to say, hey, let's send you a text message, once a week or once a week, whatever frequency you guys want to come up with this and say, how are you doing? And maybe that individual day they're not, then you're taking the cost of those phone calls and really getting a high ROI because you're only calling people that really need to be spoken to, right? So I think that's probably been the best from a return on investment standpoint and timing. And then also you like our team or your teams, they want to help people, right? Like they don't want to be making unnecessary phone calls. They don't want to be leaving voicemails. They don't want to make, 30, 40 calls in a day and only get hold of 8 people. So if there's ways that you're able to kind of increase the likelihood of someone answering the phone, that's probably it.
Wonderful. Well, unfortunately, we are out of time. And if we, again, did not get to your question, don't worry. Someone will reach out to make sure we answer it. So go ahead and drop it in. If you have it now and you still have a question, someone will get to you. As we close out here, first of all, Mark, Renee, thank you so much for a fantastic presentation. This is wonderful. I got some comments that this was from some of the audience members that this was fantastic for them and very helpful. But I wanted to encourage you all to head over to bbcexhibithall.com. Check out the Avery Telehealth virtual exhibit booth that they have there. And there's going to be a direct link in the slides. That you can access there, but you can really read up on them and what they're doing in the space and kind of what makes them unique. And there's a lot of great resources there. It's also where this webinar is going to be housed in the webinar or in the library archive rather at BBC Exhibit Hall. .com. But we are going to send a link here shortly in about an hour or so out to where you can access this recording as well as the slides from today's presentation. And then if you would like to reach out to the Avery team, feel free to do so directly. Their information is on this last slide. Also, you can reach out to me. I'm happy to facilitate an introduction if that's easier for you, if you would like to reach that team. But again, thank you, Renee, Mark, for a fantastic presentation, and hope you all join us on the next one and have a wonderful rest of your afternoons. Bye-bye now.
Thanks, Garrett. Take care.
Thanks, Garrett.